I would like to thank the organizer of this conference for providing me an opportunity to present this very innovative model and a very cost-effective model. The models which I am going to present is the goal is like reducing maternal, child and infant mortality, targeting the preventable causes. First of all, I would like to show you the situation analysis. The three countries, Pakistan, Iran and Turkey. MMR in Pakistan is 276, although we have made very significant improvement from 500 to 276. But Iran, our role model is Iran. I put the country name here, that is the reason. 33 and Turkey is the 34. Infant mortality is 72 in Pakistan and Iran 18 and Turkey only 26. Contraceptive prevalence rate is 32 in Pakistan and Iran 70 and Turkey 71. But the one important reason why the indicators of Iran and Turkey regarding the maternal health are excellent, the one most important reason which we indicate here is the number of institutional deliveries. The institutional deliveries in Pakistan 33, Iran 97 and in Turkey. If you see this graph from the last many years, we are increasing the budget in the health sectors, not only in one province, but in all provinces at the federal level. But the significant results which we want to achieve, we are not achieving. This is the story of all third world countries. This is not the story of my own country. This is all we are same. So what is the reason? The reason is the problem. Where is the problem? Allocation and the expenditure. The allocation, the health services, the primary health services where the people get the 90% services, the expenditure is only 15%. And if you say the tertiary healthcare services, only 1% services, and the expenditure is 40%. Until unless if we want to achieve the MDGs, we have to reallocate our allocation and expenditure. These are the same challenges like in all countries, all developing countries. Before designing the project, we enlist this insufficient human resource, vacant post, insufficient skills of the healthcare provider, lack of accountability is one of the major factors, attitude of the healthcare behavior is another, inappropriate behavior, weak linkages of the community with the facility, health facility, disintegrated services. These were the all challenges. How we address it, this is my model, how we address it, and at the end I will show the result. This is the integrated approach. How we address it, we link the community-based intervention with the facility-based intervention. This is the basic and the most important. The comprehensive EMAG services, basic EMAG services and the comprehensive services. If you say, the all multiple interventions which we conceive, we put in this model, and this model was conceived not only by the health department, by our partners, UNICEF and UNFPA. The UNICEF was the key partner. We implemented with the, not only with the support of UNICEF, but as a team. It is one message which I want to left here. The project can improve, the project can deliver if the government and the development partners work in a one team. And if you say in number of, this is the another linkage house, from household to the teaching hospital, we made a linkage. These are the linkages. And the one important thing is the clock. Clock shows the 24/7. We are providing services 24/7. As you all know, the time of the birth, most of the time of birth is evening or at the night. If the facility is open only for the morning time, the people will not come. The people will not trust. This is the reason where we started interventions from basic health unit to the onward. We started 24/7 and we provided an ambulance services to all area. The ambulance service on one call, pick the patient free of cost from the house and to the basic health unit, then onward to the teaching hospital or to the secondary healthcare. These are the districts where we are implementing this model. These are the 7 flood-affected districts. The flood-affected district, the southern Punjab districts, and these cities or the districts already have the poor indicators, and unluckily, these were affected by the flood, and we were forced to launch it, pilot it in these districts. Snapshot of the different BHUs. These are the interventions which we did, and these are the achieving MDG. The most important technique, other than ambulance services, nutrition, these all are, we address the first delay, second delay, third delay, and the most important, the key for success is the monitoring of the monitors by use of Android handset. Initial days, we provided the only SIM. The cost of SIM was only 300 rupees to the monitors, and we were tracking the monitors. One day, the computer operator, initial days, asked the monitors, "Where are you?" He replied that, "Sir, I am in." The computer operator told him, "Sir, you are not in Okada. You are sitting 200 kilometers away from Okada. It is a Bahawalpur district. Immediately reach to your area." This is the monitoring of the monitors, and we are doing this by just giving the SIM. Now we advanced it. Now we have provided the Android set to the monitors. When the monitors visit the health facility, there is a form. He fill the form and he take the photograph, then send it. And whenever the internet is available, the report of the monitors reach to our server, and we can compile it and we can send the feedback. Linkage with community. Another is our linkage with community. I will, in next slide. Initial phase. Objective was to expedite transfer of information from community to central MIS, to have immediate feedback automatic from the system, to reduce HR requirement for data entry. These all things are doing by the SMS. How we are doing with the SMS? The one in our remotest area, there is only, if you say the absenteeism rate, it is 0% absenteeism rate. The LHV who is sitting in the BHU at the evening or in the night, she has to send daily report of his performance through SMS. Through SMS, when she sends the report, we track her location. She can't send the report while sitting in her house, because she has to go and to perform the duty. And another is the delivery report. When she deliver a baby, she send an SMS. The SMS is like, this is the baby delivered, this is the APCAR score, this is the weight, and this is the mobile number of the mother, father, or father-in-law of that baby. And if you say this is the live report, SMS-based report, even the areas where internet is not available, and you can get the SMS report, and these SMS reports are compiled automatically, and we can get it. If you see, this is the e-monitoring, monitoring of the monitors. Now the monitors are being monitored by the Android set, and each and every step we can see on our map. This is the system, how the system is working of the e-monitoring. If you say the LHB at the facility, she is sending the daily report. If the LHB refer the case to the secondary healthcare, she sent 3 SMS. Automatically, 1 SMS to the MS or duty doctor of that facility. The second to the server for our purpose, so that we can track the patient whether how was taken care. When the birth occurs, when the LHB send an SMS to the server, what the server do? These are machine-generated automatic message. One is the message to the staff which you sent, it is okay or not. The second is the first message give to the community. One message went to the community having the message, congratulations, having the female girl, which if you, we hope staff would be good. If you have any problem, send an SMS to us, first message. Second message is after half an hour, the second message, machine generate. The second message is about breastfeeding, and then exclusive breastfeeding, then about the postnatal care. These are the 4 to 6 messages. When the machine gets the number, the machine sending the messages, and after 6 weeks, we send a message to the community for EPI coverage, for first injection, then after 4 weeks, then after 4 weeks. These are the messages, this is how we are doing this. These are the benefits. This is effective, efficient reporting and monitoring system. If you ask me the question, we have only 2 zero-level tolerance. Level 2. One is if the fake report, we get the fake report and we validate the report, then we sack the healthcare providers immediately. The second is if the healthcare provider charge the money. With all these innovations, if you see the data, this is the average ANC. The facility which was providing monthly ANC is the 26. Now if you see, it is about 141. How much unprecedented number of increases of the antenatal. If you see the delivery, there was only one delivery in the basic health unit. Now the deliveries are about more than, where 34, 35, 36, 37. These are the deliveries which are in the, if you see the average number of PNC, it increased tremendously. The two-way number are message to the community for when the mother comes for the vaccination, for the BCG of the child, she is mandatory to get the PNC coverage. We provide the PNC cover. This is the way. If you ask me how I improve the average FP client from the baseline in 1 year, I did nothing for the average to increase the family planning. Just only one intervention. We ensure the supplies of family planning. This is the only one message. If we ensure the supplies of the family planning, the CPR may increase 10 to 15%. 10 to 15%, only with the supplies. And the training of the staff is, if you see the cost benefit ratio, where we have provided the ambulance, where we have provided, this is the running cost, where we were not providing anything. The government of Punjab was spending 2,40,000 rupees. With the 2,40,000 rupees with facility, these were the baseline indicator. We added only 80,000 rupees. Just 80,000 rupees, and in the 80,000 rupees, the additional staff is, and the pay for performance. Pay for performance is another motivation for the staff. Pay for performance. So, if you see with the 80,000, ANC, 147, 37 deliveries, 58 PNC, family planning client. Even when these indicators improve, your OPD automatically improve from 400 to 1150. These are the, what are the reasons to improvement? These are the reasons are improvement which are key to success. I narrated this. There are we are providing newborn kit to the community for preventing for the hypothermia also. This is the one incentive for the community also. But the major is the linkage of the lady health worker with the facility, with this program. But what are the challenges? Shortage of funds, which are all countries, and we are addressing this in our province. We are going to integration of the program, like all programs which are related with the MNCH. We are full program integration. We are going to integrate this. Building partnership, we are searching the partners in our province. All our partners, if they have to work, we will request them to work in this model so that we work jointly to improve the model. Scaling up, the Department of Health has approved its scaling, and now we are going to scale it in a district in a phased manner. We have 36 districts. In a 1 year, we will scale for 26 districts. Thank you very much. Every delivery is safe, every child wanted.